Hello guys, today we discuss rapid sequence induction. Обсудим методику быстрой induction from journal Anesthesia tutorial of the week. You can see on this picture. Before continuing, try to answer the following questions. The answers can be found at the end of the article together with an explanation. Please answer true or false. Rapid sequence induction, cricoid pressure, risk of rapid sequence induction include. Let's begin. Rapid sequence induction (RSI) is a method of achieving rapid control of the airway while minimizing the risk of regurgitation and aspiration of gastric contents. Intravenous induction on anesthesia with the application of cricoid pressure is swiftly followed by the placement of an endotracheal tube, ETT. And of course, new words: achieve rapid control of the valves, swiftly followed by, and cardiac arrest. RSI is only required in patients with the preserved airway reflexes. In arrested or completely obtunded patients, an endotracheal tube can usually be placed without the use of medication. And of course, history of RSI. RSI was originally described in 1961 by Cervical as emptying of the stomach or gastric tube with then removed, pre-oxygenation, positions the patient supine with a head-down tilt, induction of anesthesia with a barbiturate or volatile, and a rapid-acting muscle relaxant such as saxametonium, application of cricoid pressure, laryngoscopy, and intubation of the trachea with a cuffed tube immediately following fasciculation. Modification of RSI technique in current practice. Common modifications: omitting the placement of an esophageal tube, supine or ramp position, titrating the dose of induction agent to loss of conscience, use of propofol, ketamine, midazolam, or temida to induce anesthesia, use of high-dose rocuronium as a neuromuscular blocking agent, omitting cricoid pressure. And of course, new words: omitting the placement, supine or ramp position, loss of consciousness, omit cricoid pressure. Cricoid pressure is application of force to the cricoid cartilage of the patient. The rationality is that the upper esophagus is occluded by being compressed between the trachea and the cervical vertebrae, preventing passive reflux of gastric contents and subsequent development of aspiration pneumonitis. 10 newtons of force is applied by the thumb and index finger of the system, increasing to 13 newton when consciousness is lost. 10 newton is equivalent of around 1 kilogram of pressure. This pressure is maintained until endotracheal tube placement is confirmed. On this picture you can see the surface anatomy for cricoid pressure. Position of cricoid pressure, fingers where we make some pressure. Indications. FRCA is indicated in patients who require endotracheal intubation and are at increased risk of aspiration of gastric contents. Patient's factors may dictate the need for certain elements of FRCA to be modified or omitted. Contraindications to succinylcholine, such as allergies susceptible to malignant hypothermia or hyperkalemia, should prompt usage of alternative muscle relaxants such as high-dose rocuronium. Allergic injury contraindicates cricoid pressure. Unstable cervical spine fracture will require caution in the application of cricoid pressure to the possibility of the cerebral damage. And of course, new words. Exacerbate, contraindicated, required, delayed, severe, onwards, adaptation, non-particulate. Indication of RSI. Unfasted patient or non-fasting status, trauma patients, emergency surgery resuscitation situation, and in patients with reduced consciousness level. Non-gastroesophageal reflux such as due to hiatus hernia, conditions leading to delayed gastric emptying, autonomic gastroparesis, diabetes, Parkinson's disease, history of gastric bundle surgery, patient in severe pain and with recent administration of opioids, pregnancy from the second trimester onwards. And of course, preparation. Emergency intubation checklist. Prepare patient, prepare equipment, prepare for difficulty, prepare team. And of course, proceed to RSI when all checks confirmed. Prepared patient monitoring, optimal position, good intravenous access with the fluid running, adequate pre-oxygenation. And of course, prepare equipment, oxygen supply, airway equipment, drugs. Prepare for difficult airway if anticipated, difficult airway trolley present, oxygenation plan in event of fault intubation, other specific program anticipated, and of course prepare team, confirm roles, senior help accessible. Preparation of patient. Explanation should be offered to the patient, providing a description of the planned technique including cricoid pressure, their cooperation for effective pre-oxygenation or denitrogenation will also be required. An alert patient may be offered a non-particular antacid beforehand, such as 30 ml of sodium citrate, 0.3 molar. This is the most commonly used in the obstetric population. And of course, preparation of equipment. Suggested equipment: oxygen supply machine, oxygen delivery device, standard airway equipment, difficult airway equipment, supraglottic rescue device, suction of course, monitoring, drugs, induction agent for maintenance of anesthesia, fast-acting neuromuscular blocking agent, emergency drugs, adrenaline, atropine, fluids running to exit flush for rapidly delivery drugs to circulation. Preparation of drugs, hypnotics, 5 drugs are commonly used to induce anesthesia: propofol, ketamine, etomidate, thiopentone, and midazolam. And of course we know that careful dosing of any drugs used is more important than the choice of drug. Neuromuscular blocking agent succinylcholine has been the standard of care for RSI. It is usually easily available and reliable. In full dose, it produces fasciculation, paralysis, and excellent intubation condition within 1 circulation time. Adverse effects are myalgia is the most common, but bradycardia hyperkalemia induces cardiac arrest, anaphylaxis, and the triggering of the malignant hypothermia can all occur. There is evidence of the susceptibility to these several adverse events: recent burns, spinal cord injury, or a history of muscular dystrophy. And of course, new words: available and reliable. Adverse effects: there is evidence of susceptibility. Relaxation is obtained. In some settings, side effects include interaction to provide sufficiently. Disadvantage: shall be performed. Reliable, but should be placed. Prompt. Attempts. Contentions. Rocuronium is an alternative agent. In high dose, profound relaxation is obtained within 45 to 60 seconds. One disadvantage is the lack of articulation, so other methods of ensuring adequate laryngeal paralysis must be used. The prolonged duration of action must be taken into account in the way is likely to be difficult, and if the specific reversal agent is not available. Anaphylaxis is still a possibility, but the risk of myalgia, hyperkalemia, and malignant hypothermia are avoided. A further benefit of rocuronium is the existence of the specific reversal agent. Sugammadex binds avidly to rocuronium, making it unavailable to bind at the neuromuscular junction and reversing the effect. This is useful for elective reversal preceding extubation and also for restoring neuromuscular function rapidly if required by the difficult airway plan. Sugammadex 16 mg per kg can rapidly reverse the effect of rocuronium, but usage may be inhibited by the high cost and resultant limiting stock. It may also be completely unavailable in some settings, and there can be issues with the unfamiliarity with its use. Side effects include interaction with hormonal contraceptive drugs. Other common neuromuscular blocking agents are too slow in onset to provide sufficiently rapid intubation conditions, and so will require prolonged mask ventilation of the patients. Pharmacologic adjuncts. In shocked patients, no adjuncts may be required. In patients at risk of severe hypertension during induction, for example, preeclampsia, heart injury, or an unprotected intracranial aneurysm, a bladder-suppressive response to laryngoscopy is often desirable. Opioids are commonly used. Fentanyl, alfentanil, remifentanil are all sufficiently rapid-acting for use in RSI. Lidocaine, lignocaine is also effective at reducing cough and bronchospasm solely on combination with an opioid. RSI technique. The patient should be positioned appropriately for preoxygenation and intubation. A reliable intravenous cannula should be placed, and a carrier fluid should be run freely to maximize drug delivery to the central circulation. Preoxygenation or denitrogenation should be performed as completely as possible, having regard to the clinical urgency. At a minimum 3 minutes of tidal breathing or 8 vital capacity breaths in 1 minute should be performed with an inspired oxygen concentration of 100%, and tidal oxygen fraction should be reached at least 0.8. When satisfactory preoxygenation has been obtained and all team members are ready to proceed, the chosen medication should be administered and the patient should be observed for evidence of effect. If cricoid pressure is to be used, it should be in situ and increased from 10N to 30N as the moment consciousness is lost. When intubating conditions are obtained of then fasciculation, if succinylcholine is used, intubation should be performed. If regurgitation is observed, suction should be rapidly applied and the bath should be placed in the head-down drinking barrel position to minimize the chance of aspiration in the trachea. Of course, new words, satisfactory preoxygenation, has been obtained for evidence of effect be observed for ablating the pressure response, ensuring solely confirmed, accompanied by an opioid. Once the endotracheal tube is placed, the cuff is immediately inflated. Observing chest rise and fall, tube misting and a normal feeling of airflow in and out of the endotracheal tube are useful. The gold standard is the appearance of the four-phase capnography waveform for fire breath. Also, this is reliant on cardiac output. Cricoid pressure, if used, should be released only when endotracheal intubation is confirmed. Auscultation of the chest also helps to include endotracheal intubation. Ongoing sedation should be provided, and if required, a long-acting muscle relaxant may be administered. Failed intubation. Inability to intubate the patient during the RSI should be prompt the usual approach to a difficult intubation, which should be communicated to the team prior to induction. However, if the indication was, for example, respiratory failure, allowing the patient to wake and breathe spontaneously may not be feasible. If the initial intubation attempt is unsuccessful, a best attempt at fast mask ventilation should be performed while preparing either supraglottic airway, a different laryngoscopy technique, or a new operator. Attempts at intubation should be limited, and the persistent risk of regurgitation aspiration is remembered. Rarely, a surgical airway may be required, and equipment for this should be available at every RSI. Several algorithms for managing failed intubation have been produced, including the difficult airway society guidance we can see at this size, and managers of unanticipated difficult airway too. Controversy around cricoid pressure. Also routinely performed in the United Kingdom, North America, and Australia, cricoid pressure is not established practice elsewhere and is not conscious. It is not common practice in Europe, and some pre-hospital organizations do not endorse its use. Concern includes reduced quality of laryngoscopy, lack of evidence of efficiency in preventing reflux and aspiration, reduced lower esophageal sphincter tone and therefore increasing reflux risk, worsening of undetected laryngeal or cervical spine injury, unmeasurable and likely highly variable location, direction, and degree of force being applied by the operator, patient discomfort, gagging or coughing, and ventilation is not physical and cognitive workload for the operators to avoid inflation of the stomach and associated increased risk of regurgitation, but some anesthetists may give a single breath, a several gentle breaths, to both confirm that mask ventilation is possible and reduce the development of hypercapnia, acidemia, and hypoxia. Some recent guidelines now advocate use of mask ventilation for this reason in patients at elevated risk of hypoxia, for example, the pregnant patient. Recently, apnoic oxygenation is increasingly being used, especially in critical unwell patients, to provide an oxygen-rich environment in the oropharynx to minimize hypoxia during the apnoic period to RSI. This is provided by an alternative oxygen source, commonly via nasal bronchs with the oxygen flow at 10 liters per minute or more, or via insertion of tubing carrying oxygen into the oropharynx. Some specific clinical situation. Neonates, infants, and children desaturate rapidly and can have pronounced vagal responses to laryngoscopy. A standard approach to RSI is generally performed with a range of appropriately sized equipment and carefully calculate drug dosage. Required dose may be higher than for adults on per kilogram basis. For example, a 3-year-old child will often require 5 mg per kilogram of propofol, several times higher than the proportional adult dose due to the larger volume of distribution. Atropine as additional adjunct is often used in dose 20 mcg per kilogram to reduce bradycardia. Obstetric patients in the second or third trimester of pregnancy are at higher risk of aspiration due to anatomical and physiological changes. These patients are also more likely to be difficult to intubate and desaturate faster than non-pregnant women. For this reason, RSI is employed with meticulous attention to the position, pre-oxygenation, and availability of difficult airway equipment and expertise. A routine gentle face mask ventilation may be utilized. Use of opioids as adjunct to the induction may be required if the pregnancy is complicated by hypertension or preeclampsia. As with all advanced pregnancies, the woman should be positioned with the left tilt using tilt table. Suspected or no cervical spine injury, laryngoscopy with attendant manipulation of the head and neck presents a risk of worsening an injury. Two alternative approaches are commonly practiced. One is to perform a laryngoscopy with the minimal movements of the cervical spine, often with a hyperangulating laryngoscopy if it's available. The second option is awake fibral optic techniques using local anesthesia only. Emergency in patients with aspiration risk emergence remains a high-risk time for further respiration events. Strong consideration should be given to extubating the patients awake with a full reversal of neuromuscular blockade. Left lateral head down position may further reduce the chance of aspiration. And summary. Rapid sequence induction is performed to secure the airway in patients at elevated risk of aspiration. Preparation of equipment, drugs, the team, and the patient is essential. Excellent communication should be routine. The technique may be tailored to the specific of the clinical scenario. And now we can see answers to questions. Rapid sequence induction, cricoid pressure, and risk of rapid sequence induction include. And of course you can see a research article, Emergent Airway Management Outside the Operation Room, a retrospective review of patient characteristics and complications. And of course thanks for watching and see you later. Relax, it's healthy choice.